So my critically appraised topic focused on proximal hamstring avulsions and whether surgical or non-surgical intervention was more effective in treating them. Hamstring injuries are one of the most common injuries suffered by athletes. Proximal hamstring avulsions, however, are far less common among athletes, accounting for only 9% of all hamstring injuries. They are very serious. Hamstring avulsions can either be classified as partial or complete. Partial, where part of the hamstring tendon stays in contact with the ischial tuberosity, and complete, where there is complete separation of the hamstring tendon complex from the ischial tuberosity. The mechanism of injury for this is a forced eccentric hamstring contraction with hip hyperflexion and knee extension. Patients will report either feeling or hearing a pop or snap when an avulsion occurs. They will also complain of severe pain in the upper thigh and buttock region. Following injury, swelling and ecchymosis will be present. Complete avulsions are usually treated surgically, as it has been shown that surgical intervention leads to better functional outcomes and quicker return to play times. So my focus clinical question was, do the recovery times and functional outcomes for open surgical interventions differ from those of conservative interventions in the treatment of proximal hamstring avulsions in the athletic population? Okay, so summary of search. My research was limited to level 4 evidence or higher that looked at either surgical interventions, non-surgical interventions, or that compared the two of them together. Clinical bottom line, the results of this CAT suggest that surgical intervention is quite effective, whereas conservative interventions are not very effective in treating proximal hamstring avulsions. However, there has been little research that compares the two interventions directly, making it difficult to say for sure that one is superior to the other. Okay, so my strength of recommendation grade for this CAT would be a B. This is due to the fact that based on the CEBM levels of evidence, most studies were not high quality evidence. However, the results of all the studies and the information provided in them were consistent throughout my research. For my search strategy, I looked up certain terms to guide my research. So for patient group, I searched proximal hamstring avulsions in athletes or in sport. For intervention, I searched proximal hamstring avulsion treatment and proximal hamstring avulsion surgery. For my comparison, I searched non-surgical hamstring avulsion treatment and conservative treatment. And for my outcome, I included recovery time and functional outcome measures to my previous intervention and comparison searches. And then the sources of evidence I used were Google Scholar, PubMed, and Sport Discus. For inclusion criteria, all the studies had to be in English and published no earlier than 2012. The subjects all had to be athletes that suffered a proximal hamstring avulsion that was at least partial. All studies had to be at least CBM level 4 evidence, and each study had to either look at surgery, conservative rehabilitation, or compare the two together. Exclusion criteria included studies that were not in English and published before 2012, studies that looked at other treatments such as endoscopic repairs and corticosteroid injections. And yep, I think that's it. So there were a total of 7 studies included in this CAT. 5 studies were either cohort studies or a case series, and 2 studies were systematic reviews. None of the studies contradicted one another, and they all included information and results that answered the focused clinical question. The first study I looked at was by Blakeney et al. This study looked at subjects who underwent open hamstring avulsion surgery. Results of this study showed that a year post-op functional outcomes were in a year after hamstring surgery, functional outcomes were improved significantly. The Perth hamstring assessment tool was used to measure patient functional outcomes. The scores were improved by 34.7 from before surgery to a year after. The next study was done by Shambaugh et al. This study compared surgery to conservative treatment. The conservative treatment included rest, ice, and physical therapy. And the results showed that the surgical group had higher scores out of 80 on the lower extremity functional scale shown here, or the LEFS. Also, while surgical subjects were able to return to their pre-injury level, only 3 of the conservative treatment subjects, all of the surgical subjects were able to return to their pre-injury level, and 3 conservative treatment patients were unable to do that. Next, a study done by Skara et al. Looked solely at open surgery, results showing progression to sport-specific activities and return to play time around 12 weeks. Isokinetic testing was done by the Biodex 600 dynamometer shown here to assess strength of the hamstrings. While results showed that subjects were only able to get an average of 85% of their hamstring strength back compared to the uninjured side, this was justified by patient reports of fear of re-injury and not trusting their affected leg after surgery. This factor could have affected the results of this study, including return to play time and the functional outcomes. So the next study was done by Subu et al., and it looked at open surgery for treatment, but this one split subjects into 3 different groups. So there was one group that was called early, which meant that surgery was performed 6 weeks or less after injury, the delayed group between 6 weeks and 6 months after injury, and the late group, which was 6 months after injury. Some patients were given a knee brace after surgery, which increased the time it took for return to play because the joint was immobilized, which delayed rehabilitation time. The knee braces were mainly given to subjects in the late group. This was due to more retraction being needed to perform the surgery, making the procedure more complicated. So results showed a 9-week difference in return to play time between the early and late groups, with the early group's time being faster. Okay, so the next study by Hoffman et al. Looked strictly at conservative treatment for hamstring avulsions. The treatment consisted of stretching and flexibility exercises, as well as isometric strengthening exercises. So they used the LEFS as well, and the score averaged about 70.2 out of 80, and subjects returned to play as early as 12 weeks, like surgical subjects in other studies, but not all patients returned in 12 weeks. Results also showed that unlike subjects in other studies that underwent open surgery, many subjects in this study were not able to return to their pre-injury levels of activity. This showed that while conservative treatment may be effective, there are also strength and endurance deficits that are present when this type of treatment is performed. Okay, in a study by Vandermeet et al., so this was a systematic review, and a total of 387 patients total were included in this systematic review, all receiving open surgery repairs. The results of the study showed that subjectively, functional outcomes were high. However, not as many patients were able to return to pre-injury level at the same rate, if at all, as subjects in other studies. The quality of studies in the systematic review were also very low, making it difficult to confirm the results present in this review. Lastly, a systematic review by Harris et al. Looked at 298 subjects, with the vast majority of them undergoing surgical repairs and very few who received conservative treatment. 82% of all the surgical subjects returned to play at pre-injury level, while 14% of the non-surgical subjects were able to do so. The results from this review show that subjective outcomes and the return to play times were much higher in subjects treated surgically, and the subjects who received surgery, also the ones that received surgery closer to the time that their injury occurred, had better outcomes and satisfaction rates. So, for the implications for practice, education, and future research, all studies in this CAT provided consistent evidence that surgical intervention had faster return to play times and better functional outcomes. Harris et al. Did suggest that complete tears are better treated surgically due to the severity of the injury and the complete separation from the ischial tuberosity. It was shown that conservative treatments often lead to deficits in subjective outcomes for pain and strength, as well as objective outcomes. It was also shown that surgery had a strong correlation with subjects returning to play at pre-injury level. Conservative treatment averaged about 4 months, while all the other studies showed that surgery averaged about 12 weeks return to play time. Timing of surgery also played a part in return to play time and functional outcomes. The faster you get surgery after being injured, the faster return to play time you have. There are very limited studies that exist on this topic that directly compare surgery to conservative treatment. There are also little to no studies that discuss other treatments of hamstring avulsions that aren't open surgery or rehabilitation exercises. So future research needs to be done to investigate these topics more accurately to say what the best treatment option is for proximal hamstring avulsions. And here are my references.